I'd like to thank GETA for giving myself and Genevieve the opportunity to come here today to talk about a different kind of treatment for DEEs, one that brings together MICE and DEE into a mental health intervention. And as we've already heard from Ingrid this morning, it's really the brainchild of Ingrid, who heard about the MICE study at an international meeting and recognised its potential in addressing a significant service gap in the DEE population, that being the treatment of mental health disorders and behavioural disorders. And so today, firstly, I'm going to talk about the UK MICE study, and then Jen's going to put it into the DEE context, and then finally I'll finish by speaking about our adapted MICE study that we're running here out of the Austin. So as Ingrid mentioned this morning, over 90% of individuals with DEEs have intellectual disabilities, and a range of mental health disorders occur in more than 70% of individuals, including behavioural problems, mood disorders, autism spectrum disorder and psychosis. And as children with DEEs grow, these mental health comorbidities often eclipse seizures as the problem of greatest concerns. Unfortunately, as individuals with DEEs have complex diseases, mental health disorders frequently go undetected and undertreated, as often the symptoms are attributed to their intellectual impairment or cognitive disability, or maybe related to their seizures or the side effects of anti-seizure medication. And then further barriers to managing mental health disorders in this population include a lack of clinician experience in addressing the complexity of this population, and also a lack of standardised assessment procedures and evidence-based treatment options. So the mental health intervention for children with epilepsy, MICE, study was the first randomised controlled trial of a psychological therapy in children and young people with epilepsy. It aimed at expanding access to mental health care for young people with epilepsy by incorporating a telehealth-based therapy into epilepsy clinics across England and Northern Ireland. And in this randomised controlled trial, the intervention group received a treatment called MICE, which is a modular psychological intervention designed to treat a range of common mental health conditions using evidence-based treatment approaches like cognitive behavioural therapy and behavioural parenting strategies. And then in this study, the intervention MICE was compared to a control group that did not receive this intervention and instead got their standard care. 334 children with epilepsy took part in the study, and after 6 months, the group who received the MICE treatment showed a significant reduction in their mental health symptoms compared to a control group of children who did not receive the intervention. And this reduction in mental health symptoms was retained at 12 months, where there was an even greater difference between the treatment and control groups. So the findings of the MICE study at 6 and 12 months post-randomisation showed that children who received the MICE intervention had improved mental health compared to those who just got their standard care. Additional analyses showed that the MICE intervention was effective across a range of subgroups, including those with intellectual disability and autism spectrum disorder. However, in that study, for children with intellectual disability, the intervention was almost entirely delivered to the parents instead of the child, and a case review showed that some of the strategies were not effective for children with intellectual disability, and others required significant modification. So it was evident that adaptations to the original MICE study were required for children with intellectual disabilities and complex mental health problems. So with this in mind, as Ingrid introduced, we went to London last year to spend a week at the Greater Ormond Street Hospital with the UK MICE team, workshopping adaptations we might make to the UK protocol to ensure that it's appropriate for children and adults and families of those with DEE. So myself and Genevieve brought the neuropsychological and behavioural perspective. We were joined by Briley Forster to bring her experience in working with these families, and also Ingrid with her DEE expertise. And we were working with the team in the UK to identify ways in which we could amend the existing intervention. So that leads to one of the key objectives of our trial, which is to adapt the UK intervention so that can be delivered solely to the parents of children with children and adults with DE, as we know that these children and adults will be unlikely to engage with psychological therapy over telehealth. And the rationale for this is underpinned by the family being the centre and the experts of the person with DE. So Genevieve is now going to go through some of the theoretical background for how we adapted the MICE protocol treatment.
Thanks, Eliza. And just to start, as Ingrid said before, I work in adults, and the need for MICE-DEE was really brought home to me recently when I was seeing a person with Lennox-Gastaut who was having some sort of lashing out behaviours, and trying to find a psychologist who is happy to work with adults with intellectual disability and complex medical conditions is really hard. So I'm probably preaching to the choir there, but it really sold how much we feel like this is needed. So I want to talk to, as Eliza said, the scientific and philosophical evidence base of the trial. We know that challenging behaviours and mental health difficulties often the tip of the iceberg, and really what looks like might be lashing out or challenging or obstructive kind of behaviour is often conveying a meaning or a function. In people that can't readily communicate, this is how they're communicating what their needs are. And so we know that, for instance, punishments and other sort of traditional kind of ways that you might learn to discipline and train people in behaviour don't really work. And so I'll just talk briefly about why. And in particular, the lens we're taking is that in the original MICE trial, although they did have people with DEE, the modifications they made to adapt for the DEEs were on the fly, whereas we want to take a systematic approach from the outset to make sure that our approach is appropriate. So traditional psychological therapies, and I'll use a made-up example based on myself to illustrate the point, but if I was, for instance, a pack-a-day smoker and I also wanted to get really fit, and if you knew how lazy I was, both of those things are equally unlikely, then I might use to change my behaviour a cost-benefit analysis, in that I want to get fit, and smoking a pack a day does not fit into that goal of getting fit. Therefore, I might reason through with myself that this smoking behaviour is not congruent with the bigger goal that I want. But we know that this aspect of cognitive behavioural therapy is a challenge for a lot of people with DEEs who might struggle with making those sort of cognitive connections between the behaviour and their goals, and in terms of planning, things like that. Another aspect that we know doesn't really work when people have cognitive delay or intellectual disability is punishment. Punishment generally doesn't work anyway. If I were to try and quit smoking by depriving myself of chocolate every time I did smoke, then I would probably just feel bad about myself on a number of levels rather than it reducing the behaviour. So with that in mind, we looked to scientific evidence around what does work in people with intellectual disability and in changing behaviour. And the two aspects that have a good, solid scientific basis are around creating a positive environment that meets the needs of the child, and then figuring out why the person, the young person or the child, is behaving in that way, so that we can give them an alternative way to behave. Very briefly, setting the scene, a lot of work has been done in things like Down syndrome and intellectual disability that was picked up by the World Health Organization, that really creating a home environment with the family that meets the needs of the patient, but also the parents and the family, is crucial to mental health well-being of the patient, but also the caregivers. And so to do that, we really need to understand what the person with the DEE needs as a baseline of how we can best meet those needs. For instance, this comes from the World Health Organization model for how we think about disability now. Rather than focusing on what the person can't do, let's think about what they can do, what their strengths are, and what their needs might be. So in this instance, we're thinking about what are the barriers to the person behaving well in terms of, are they comfortable, really basic stuff, in toileting, are they able to sit comfortably in their wheelchair? Do they have fun? Do they connect well with family? They're often can be quite social, bright kids and young people. And are they getting sufficiently socialised and given sufficient social kind of activities? And so this might feel like, throughout this talk, I really want to make it clear, it might feel like, I'm sure a lot of you do have this mindset, are constantly thinking like this, and really the MICE-DEE model is for us to bring a fresh set of eyes to the situation. The other aspect is teaching different and more positive alternatives to behaviour. So the challenging behaviours in DE are, we suspect, often due to the person trying to communicate that they're hungry, that they're tired, that they've just had a seizure, that they're generally fed up. Or perhaps they want something, they want more attention, or they want to feel good in some way. And so there's a really good psychological framework for this that we've been using for many years called ABC analysis, where really we're taking a lot of time with our families in the MICE trial to understand what is the behaviour, what do you want to change, what does it look like when this behaviour is gone, and then to try and understand patterns leading up to the behaviour. So is there something that triggers these behaviours? Sometimes there isn't. And then at the outset, what happens when they do the behaviour? Do they get attention from mum or dad? Do they get a treat to get them to be quiet in public if they're acting out? Or is it a way for them to escape from things that they don't want to do, like refusing to go into a day program or those sorts of behaviours? So all these behaviours that are really challenging in the moment, we would argue have a function that we need to try and understand. And so then what we do in MICE-DEE is work with our families to develop an alternative to that behaviour that is more acceptable to you and your lifestyle as well, and really drawing on the strengths of your individual child or young person, not a one-size-fits-all kind of approach. So again, to reiterate, like you've probably all thought around these sort of concepts in trying to manage challenging behaviours, but really what Eliza's going to talk about is that MICE-DEE is us using our psychological expertise to coach the family with a fresh set of eyes and over weekly support interventions. So support for the family and carer and a fresh set of eyes. Eliza's going to talk to finish off in a bit more detail about what that looks like.
Okay, so the MICE-DEE study is a nationwide, multi-centre randomised control trial that uses this adapted UK intervention to identify and treat mental health disorders in a more severe population of children and adults with DEEs. And as we've alluded to, one of the key differences is that in our study, the intervention is delivered solely to the parents and long-term caregivers rather than to the patient themselves. And so the focus is on upskilling parents and caregivers with education and strategies to be able to better manage their child's complex mental health and behavioural problems. And so similar to the UK study, we'll be comparing this against standard care for mental health disorders in this population. So we're conducting a pilot study of 80 patients, and the main aim is to determine the feasibility of the trial. So in other words, can we actually enrol, retain and deliver the intervention to parents across 6 months, as well as looking at the time and the number of sessions needed per family for the treatment and management. And then the secondary outcome of the trial will estimate the efficacy of the intervention in reducing symptoms of mental health and behavioural problems. So involvement in the trial will involve an initial assessment followed by weekly telehealth sessions with a therapist. And the number of sessions required will depend on your individual goals and what you're working on, but the minimum number of sessions is 10 and the maximum is 22, and these occur over the course of 6 months. And as Jen spoke to, many of the strategies will be familiar to you, but I think one of the things is that you're able to discuss with your therapist what is and isn't working and problem solve collaboratively about ways in which the intervention and the strategies can better be suited to your child and to your family. So therapists in the trial will be under the supervision of clinical neuropsychologists, myself and Genevieve, and we're going to be providing additional guidance and strategies with the therapists. And so it's about getting this intervention and this treatment, but also about having the therapist as your coach, supporting you and getting feedback from your therapist across the trial. So to participate, children are above age 4 with a diagnosis of a DE, and they'll meet the eligibility criteria on our assessment measures. So that's just demonstrating significant impairing mental health and behavioural problems that are amenable to intervention as well. So parents will complete all of the baseline measures before being randomised into one of 2 groups. So that's the MICE intervention group and then standard care. The primary endpoint of the trial is 6 months post-randomisation with an additional follow-up at 12 months. And so we've been lucky to have Dr. Sophie Bennett, who was the lead author of the UK MICE study. She was visiting us for 2 months. She only left a couple of weeks ago, and during which time we completed all the adaptations to the protocol. We've had our ethics approved, and we're now running a pre-pilot of the intervention with 10 families just to make sure any additional modifications are addressed before we're launching the main trial in a few months' time. So I'd like to thank all the incredible people I work alongside in this study, particularly Professor Ingrid Sheffer and Briley Forster, and also acknowledge all the families that have been interested in taking part in this study. If you are interested in learning more about the study or connecting with the team, you can email myself, or we have a MICE-DEE email address as well. And so we can register your interest so that when we're ready to launch the main randomised trial in a few months' time, we can get in contact with you to complete those baseline and screening measures to determine the eligibility to participate in the trial. So thank you very much.